Okay, it's 10 o'clock and it looks like people are still joining, so maybe we can give it a few more minutes.
Yeah, I think so, because we
Great. I think we can give people still joining maybe 2 more minutes. Then we'll begin the session. Thank you for your patience, everyone.
okay.
It's 3 minutes after 10 now. Is it fine that we begin? Or we wait until 5 minutes, maybe?
No, I think, let's begin, I think, because, we are already 3 minutes over, so I think let's begin.
Great. Okay. Great. All right. Welcome, everyone, to this webinar today. This webinar is on facilitators and barriers to implementing Self-Help Plus 360 in Uganda. And we would like to know who you all are and where you're all calling in from. I know that we're all dialing in from different parts of the world, so it would be nice just to write in the chat just a few words about who you are and where you're calling in from. And for a bit of housekeeping today, this webinar will be recorded just for your information. And if I'm not able to mute all the participants, I kindly request that you please mute yourself so that we don't disrupt the speakers today. And also, we will first start off with the two speakers, and then we'll have a round of questions and answers. So while they're speaking, and then if you find that you have questions during the sessions, can you please write them in the Q&A, and then I will be able to convey them to our speakers today. Right. So for the agenda today, we have two presenters from HealthRight, Dr. Nauraj Upadhyaya and Max Lekum, and they will begin their presentations in the first 30 minutes of this webinar. And then we'll have some time for questions and answers afterwards. So going into introducing our two speakers today, I'll start off by introducing Dr. Nauraj Upadhyay. He is a public health researcher and mental health system specialist. Dr. Nauraj is currently the Global Mental Health Director at Health Right International, which is based in the US, but they work in several parts of the world, including Uganda. And he is also associated with the Department of Public Health at the University of Copenhagen in Denmark. Dr. Nauraj has over 18 years experience in community health, mental health, and public health systems. He has experience of working in humanitarian settings in Afghanistan, in Burundi, in Nepal, in Uganda, and in South Sudan. He has co-directed the Scaling Up Grant on Self-Help Plus in Uganda, which this webinar focuses on today. Dr. Upadhyay's work focuses on community mobilization, community system strengthening, mental health systems, community mental health, and policy engagement. Thank you for joining us today, Dr. Nauraj. And then moving on to our second speaker, that is Max Leko. He is a research collaborator and a Self-Help Plus implementation manager at Health Right International, and he's based in Arua in Uganda. He has over 10 years experience and has conducted qualitative and quantitative mental health research with violence-affected populations in Uganda and South Sudan. Max has been instrumental in 2 randomized control trials on Self-Help Plus in Northern Uganda. He has also led integration of Self-Help Plus through multi-sectoral partnerships in Uganda, of which we're disseminating the results today in this webinar. And he has also co-authored several papers that have been published in peer-reviewed journals, including the paper, the commentary essay, Self-Help Plus 360, novel model for scaling up a mental health and psychosocial support program in humanitarian settings. He holds a Bachelor of Philosophy and a Master's in International Development. Thank you. Now I will hand it over to Max, who will begin presentations.
Thank you very much, Jacqueline, for the wonderful introductions and excellent opening remarks. Just like you mentioned, I will start by giving a brief background of the Self-Help Plus intervention. I will speak about the development of its contents and some of the adaptations that we have gone through and the research processes that we have gone through to test SS Plus, not only with the South-Sudanese refugee women, but also with the South-Sudanese refugee men in northern Uganda. And then later on, my colleague Nauraj will come to explain SS Plus 360, which really focuses on the integration of SS Plus into the wider humanitarian programming. Most of you probably are aware that across the globe right now, a number of people are exposed to very difficult and life-threatening situations, which are coming from a number of factors. And the most significant of this right now is armed conflicts. We have armed conflicts taking place virtually in every part of the globe. And right now, the world's attention is focused on 2 major armed conflicts, the war in Ukraine and the war in the Gaza Strip that has displaced millions of people and led to loss of lives of thousands of both civilians and men in uniform. And but apart from armed conflict, there are a number of other factors that expose people to adversity. For example, environmental disaster, displacement, which often comes also as a result of armed conflicts. We have endemic poverty and interpersonal violence. When people are exposed to all these difficult situations, most often their mental health is affected. And because most evidence-based interventions we have right now in the area of mental health and social support are too resource intensive and rely on highly skilled mental health professionals who are in most cases non-existent in the humanitarian settings most people who need mental health services actually do not get these services because of the scarcity of the mental health professionals. So they live for a long time with the effects of chronic stress, anxiety, depression, post-traumatic stress disorder. And when they're affected by all these, the ultimate impact on these individuals or affected populations is their impaired ability to function as normal human beings. So in the absence of trained mental health professionals, either for direct service provision or for training and supervision of non-specialists, innovative solutions need to be developed. And these are solutions that can easily be implemented or delivered without an extensive workforce in mental health. And SS-PASS has been developed in that regard, simply to bridge the enormous gap that exists between supply of mental health professionals and the enormous demand for care in the communities. And this is exactly what we are presenting today. SS-PASS has been a long product of the research that has been conducted among the South-Sudanese refugee populations in northern Uganda. You probably are aware that the current conflict in South Sudan, which started way back in December 2013, had displaced more than 2.2 million South Sudanese into the neighboring countries, Uganda inclusive, but of course a similar number remains internally displaced within the country, as you can see on the map on the right-hand side of this screen. But the country has had a long history of war dating back to 1955 during the First Sudanese Civil War. So as you can see on the map, the refugees that have come from South Sudan into Uganda as of November 30th are about 915,000. But the good news is that Uganda has a welcoming refugee policy in the sense that the government grants refugees the right to work and to set up businesses. There's also freedom of movement, and there's equal access to government provided services, for example, education and healthcare. And all this enhances economic interactions between the refugees and the host communities. And one key aspect of the welcome refugee policy that the government of Uganda has is the fact that in Uganda, refugees are actually not put in camps. They are settled where they're given small plots of land which they can cultivate in order to improve on their livelihoods. But despite all these interventions from the Ugandan government, there are still ongoing challenges for the refugees to secure their basic needs. As of 30th November 2023, the country had 1,604,813 refugees spread across the different refugee settlements in Uganda. Majority of them are settled in the refugee settlements in West Nile and in the greater northern part of Uganda, probably because these refugees settlements are very close to Juba, the capital of South Sudan, which is the epicenter of the current conflict in the country. But we have refugees also spread across other parts of the country, in the southwest, in the midwestern parts of the country. So we have out of the 1.6 million refugees in the country, the refugees from South Sudan contribute the greatest percentage, accounting for 57% of the total number of refugees in the country, followed by the Democratic Republic of Congo, which stands at 32%. And then at the bottom of the ladder is Rwanda at 1%. I would like to briefly explain to you what the intervention Self-Help-PASS is. Self-Help-PASS is a guided intervention. It's a low-intensity psychological intervention that has been developed by the World Health Organization. It's used for managing stress and coping with adversity. Adversity resulting from any type, whether it is chronic poverty, endemic community and gender-based violence, or long-term armed conflict and displacement. So SS+ is helpful in all these situations. It's delivered by briefly trained non-specialists as opposed to other evidence-based interventions that rely on highly trained mental health professionals, like I said before, who in most cases are non-existent in many settings across the globe. The non-specialist supervisors are easy to train as they require fewer resources, as will have been used to train mental health professionals. We all know what is required to train, for example, a psychiatrist or a clinical psychologist who deliver some of the interventions that can only be delivered by trained mental health professionals. The format is suitable and flexible in the sense that it can reach up to 30 people in a single workshop, as opposed to other psychotherapeutic treatments, which only reach individuals or a few groups of individuals. So in terms of reach and coverage, SS Plus is at an advantage in this manner because it addresses, first of all, many mental health concerns at the same time, but also the number of people is able to reach at a time is much bigger than other current evidence-based interventions can reach. And all the information about SS Plus is available on the WHO website. The intervention has got two major components. We have the pre-recorded audio material, which is delivered through 5 weekly sessions lasting about 90 minutes each. The participants don't just come to the sessions to listen for the whole of the 90 minutes to an audio session, but the sessions have been designed in a way that they're very interactive. Participants during the sessions have an opportunity to have small group discussions, and there's a co-facilitator and a lead facilitator who are responsible for delivering this audio, and they're able to attend to some of the specific needs of the participants within this session. But apart from the pre-recorded audio, we also have the illustrated book, which is commonly referred to as Doing What Matters in Times of Stress. The book can be used as a standalone product, but it was designed basically to reinforce some of the concepts from the audio, mainly for people with low literacy skills, because the book is structured with pictures and words attached to it, which makes interpretation easy, mainly for people with the low literacy. There are a number of reasons as to why SS Plus was developed, and as to why it's preferred in order to reach many more people, because like I mentioned before, it's an intervention that is very flexible in its format, and given the fact that from the statistics from the UN, 1 in 5 people who experience 1 in 5 people in humanitarian crisis actually experience significant mental health concerns in their lifetime, which means that we have a greater number of people who need mental health services. But because the demand is high and the supply of mental health professionals is low, innovative solutions like SS Plus come to address this gap. As a result, SS Plus has been preferred because of a number of reasons, as have been outlined here. As mentioned before, intervention is brief, doesn't rely on a trained mental health professionals. The lay providers who deliver the intervention are easy to train and to supervise because they deliver pre-recorded audio content, which is accompanied by an illustrated self-help book, which is pretty easy to interpret. And then you realize that most psychotherapeutic treatments with the strongest evidence right now only reach one mental health problem at a time. For example, they will address post-traumatic stress disorder or depression or anxiety. But for SS Plus, one manual that we spoke about can address all these problems at the same time. So one manual works for many possible problems, and that's really is a good news for us, because we know that there are multiple forms of psychological distress which are often faced by people in humanitarian crisis, and an intervention like SS Plus goes a long way in addressing this gap. Intervention has proved to be helpful in a wide range of settings. It has worked in humanitarian settings, like I explained before. We have conducted research and implementation aspect of SS Plus along the self-managed refugees, but also it has worked in other contexts that are not necessarily humanitarian. This really it benefits anybody who experiences psychological distress, regardless of their context. It's easy to adapt locally, implement, and scale. The first version of SS Plus didn't come into, for example, the languages that we have adapted in. Right now, SS Plus has been adapted in several languages, which are all published on the WHO website. The implementation aspect of it has also been very easy. My colleague now, as we speak about this in the coming minutes, we have successfully scaled this up pretty easily through SS Plus 360 model with our humanitarian partners in Uganda and also the government of Uganda, specifically through the Ministry of Health. Like I mentioned before, the format is flexible for large groups of people, as opposed to other evidence-based interventions that only reach individuals or just a few groups of people. Throughout the pre-recorded audio material and the illustrated book, there is no mention of mental health. And you know, mental health is pretty much associated with stigma. And the format of SS Plus is in such a way that it addresses that. So there's low risk of stigma because it's simply targeted towards thinking too much, which of course many people do not consider as a mental health concern. So people find it easy to join the sessions or to identify themselves with SS Plus because of the low risk of stigma. Like I mentioned before, we have gone through a number of research phases in order to have a final product of SS Plus that is in usage right now. Just like it's the practice with so many interventions, especially in the sector of health. New interventions like this will be tested through a rigorous process of research so that we minimize the adverse effects that possibly will have come as a result of the intervention. We also wanted to make sure that we produce something to the populations that has been tested and tried and that has been known to work with the strongest evidence possible. And that's why we conducted a fully randomized controlled trial, which in the field of research is the epitome of scientific research. There is no amount of evidence that a randomized controlled trial can actually produce that anybody else will doubt or produce a result that is otherwise. So we went through a number of phases. First, we did a formative study where we conducted a needs assessment with the South Sudanese refugees. During this phase, we reviewed the existing literature in regard to mental health and psychosocial support, the existing services available to the populations. We conducted a number of qualitative interviews with a sample size of 86. Once we completed that phase, we then moved to piloting. We did both controlled and uncontrolled pilots in order to test, how this intervention could work and to refine our research procedures for a fully powered, randomized controlled trial. Then after piloting, we then moved to a fully powered, randomized controlled trial where we reached over 600 participants. I will just move it to the next slide and explain to you some of the brief results that we got from our randomized controlled trial. On the left-hand side of the screen, you can see the heading guided self-help to reduce psychological distress in South Sudanese female refugees in Uganda, a cluster randomized controlled trial. This was a paper on SS Plus RCT, which was published by the Lancet Global, where the full results of the SS Plus RCT have been published. But this is not the only RCT that has been conducted on SS Plus. There's also a full RCT of this nature that was conducted in Turkey, and both RCTs have shown similar results, though they were conducted with different participants in different contexts. So for the RCT that you are seeing now, which was conducted with the South Sudanese refugee women in a rhino camp, we had 694 eligible respondents, participants who took part in the study. We had two arms of the study. In a randomized control trial, we always have the treatment arm and then the control arm. So the treatment arm received the SS+, then the control arm received enhanced usual care, which consisted of the usual services that HealthRight was providing to the population by then. And after analysis, we found strong improvements in the treatment group, that is 3 months after post-intervention. So what happened was before the participants were enrolled into the study, we did the baseline assessment, then went either into the treatment group or into the control group. Then after 5 weeks for the treatment group, the 5 weeks corresponded to the 5 weekly sessions of SS+. Then those in the control group received also the usual services that HealthRight was providing by then for 5 weeks. Then we did the post-intervention assessment using the same tools at 5 weeks. Then we found strong improvements were recorded in the treatment group other than the control group. But also we did the same post-intervention treatment 3 months after the intervention. We found the same results. Then qualitative interviews were also conducted after the whole process was concluded, and then we found SS+ was highly relevant, was safe, was acceptable, and was scalable. And this is what my colleague now, Raj, will be speaking about in a few minutes from now. Then we had a data safety monitoring board to monitor the safety of the participants. And the data safety monitoring board investigated 6 adverse events, and none of them, fortunately, was evaluated to be related to the intervention. That means the information, the data that we got that the SS+ is safe also was confirmed partly by the report of the data safety monitoring board. SS+ initially was tested among women. The first randomized control trial was with women. Somebody would ask why we left men out. In the initial piloting, we included both men and women, but we realized that the men had other problems that could not be addressed by SS+. SS+, as I mentioned before, is useful in addressing psychological distress. But we found that the men had other problems. For example, they will come to the session when they are drunk, then they will be disruptive to their colleagues. So we took a deliberate move to adapt SS+ to suit the needs of men, where we included an alcohol-focused component to it. So later on, we then did a feasibility randomized control trial with substance between men. The results of this are promising, but of course, they will need to be confirmed through a fully powered randomized control trial. And the alcohol-focused component was delivered through AssistPI. We got a local illustrator to modify the intervention book. Then we did cognitive interviewing with the participants to explore aspects of relevance, comprehensibility, the acceptability of the contents. Then we trained the facilitators and made the necessary adjustments. Thank you. This is where I will stop with the background and the research aspect of SS+. I will hand over to my colleague, Nawarad, to take us through SS+ 360 model.
Thank you, Max. Thank you. Let me share my screen. Is it visible? Yeah, okay.
It is, yes.
Lovely. Thank you. Well, thank you, Max, for your, the background information about Self-Help Plus. As my colleague Max has said that actually this intervention was really effective, on based on the trials conducted in Uganda, Turkey, and Western Europe. And then we had a question, okay, how to scale it up into, greater setting? So, we had two options. One that, health right could actually do, increase the geographic coverage and actually extend the program, and then actually in scale it up. But then we thought that, we are, small, international NGO, and we have limited reach. So we cannot reach more and more people. So actually we thought that it's actually a best idea actually to train the government, the NGO, and the UN agencies who are already working at scale. And if we could support them, actually they can reach more and more people. So that was the idea that it actually developed this self-help plus 360 model. And this is a model of a consultancy support model to other organizations, be it the government or NGO or UN bodies, to actually support them in integrating self-help plus into their regular programming. And actually this actually has a full project cycle, and we start with the needs and resources assessment. We look at we conduct lots of interaction with the partner to look at the context of their programming. Where do they do the culture, the participants, and their organizational structure, the programs. So actually we actually look at all those aspects, the prerequisites for the self-help plus integration. So after all the needs and resources assessment have been done, based on the findings, then we adapt our self-help plus materials. For example, the case examples are adapted, some words are adapted, or the language is adapted. So all the tools and materials and manuals is adapted based on the context of the partner. After these tools are completed and adapted, then actually we run a 1-week training for the partners staff to develop them as self-help facilitators. The training is for 5 days, full 5 days, and then during the training, actually we use competency assessment before, during, and after, so that we make sure that all the trainees have minimum competency level to actually deliver the intervention. And as we also actually engage the partners, the finance staff, monitoring and evaluation staff, and program staff, so the M&E staff actually do the baseline assessment with the potential participant using the screening tool like Kessler-6 for distress and WHO5 for the functioning, function impairment. And based on the symptom severity and effect on the function, we actually determine whether they are severely affected or mild to moderate. So only people with a mild to moderate mental health problems are enrolled in our self-help plus intervention. And then the intervention takes place for 5 weeks, weekly, over 90 minutes period, and facilitated by the audio, as my colleague has explained in detail. So I won't go into that, but I will stress that during the implementation process, there is a constant supervision from health right technical team. And then after the implementation, the M&E team of the partner organization, they do the post-intervention assessment. And then this all fit into the improving of the intervention design and scale up. And in Uganda, actually, we have piloted this with BRAC, and we integrated self-help plus intervention into their financing for refugees program, and the strengthening safety, protection, and peaceful coexistence space program for the refugees as well as the host communities living in and around Rhinos settlement. And we also integrated self-help plus intervention with the Ministries of Health COVID-19 response plan in 19 health facilities in Kampala, Wasiko, and surrounding areas. Actually, this process starts with a teaming agreement. We had a teaming agreement with the partner, and then after the teaming agreement, we had series of workshops to develop the implementation plan, to look at how they are situated, their program is situated, what we need to know. So actually we involve the staff from the field, from the national office, and from the global office, and we actually develop the implementation plan. Together also we decided the joint timelines of when HealthRight and the partner will do the the training, supervision, and all other assessment. The finance staff also actually jointly sat together with the program and many staff of both the organization and detail the budget aspects. And once all these aspects were clear and agreed upon, we had an actual contract signing ceremony to kickstart the implementation. So what are the success? Actually, we due to COVID, actually our time was very limited, and we only had 6 months of implementation period. And even in the 6 months implementation period, we actually successfully implemented this intervention, and many people were interested to actually take part in. So I think it's a bigger success. And thanks to our partners, Ministry of Health and BRAC, for making it happen. And actually we adopted and this scaling strategy for the government and also for INGO. So we have two models of adaptation that are ready for scale in other setting if other stakeholders are tested in. And as a byproduct, because of seeing this scale of initiative, actually even as CR in Uganda was interested actually to hire us to do the same thing for their peace building program. And actually we supported them in integrating self-help plus into the peace building program for South Sudanese youth volunteers in their refugee settlement. What were the challenges? The challenges were that actually this partnership process is a very long and tiring process, because the partners also have their own dynamics. They also have like layers of the governance at the field level, at the national level, at the global level, and they also have different understanding. So also we also have different understanding and philosophy. So it was very difficult at the beginning to actually discuss and actually find out what we are going to do, how we are going to do. And one of the partner actually dropped out from this initiative because the partner thought that 6 months of implementation period is actually not enough. And then the budget formatting also did not allow them to actually put their needed budget. So there were also lots of challenges. As these big organizations also have their own mechanism of of functioning. So we had challenges of retaining all the three partners. So one partner dropped. This shows that actually in the partnership process, we need to have actually more time and more face-to-face discussion. Because of the COVID, actually we did most of the consultation over Zoom, and I think Zoom has actually some limitation, and I think you may also see that this presentation might also have limitation. If we were face-to-face, maybe it would have been even better. So we recommend that we need to have a face-to-face interaction with the partners in developing the partnership. Briefly, I talk about the facilitators and barriers of scaling up self-help plus in Uganda. As my colleague has said that many people found that actually we did a qualitative interviews and the research among the respondent, among the facilitators, among the staff and the participant, and all of them said that it is a simple and adaptable tool and easy to implement. Second, the partners have now the internal capacity. They are they have the trainers, they have any system in place, the finance system in place to actually run this intervention on their own. They don't need the support of HealthRight anymore. So I think that's a facilitating factor. And the co-development process actually has really helped actually to understand each other and also the concept of the intervention and why it is important to be integrating into the regular programming of the partners. So the continuing involvement of the stakeholders in the co-development was really a facilitating factors. Many people were motivated by this intervention because this intervention not only helped the participants, but also the facilitators and all of us who were actually involved in the design, in the discussion, and in the implementation supervision. All of us actually benefited, and in terms of reducing our own stress and our own daily challenges. And there are more and more interest from the stakeholders, and actually there was a growing demand of people that wanted to be enrolled in our intervention, but unfortunately because of the limited time and budget, we could not actually involve all of them. So that shows that there is a big demand for this intervention in Uganda. In terms of barriers, actually the concept was somehow vague in the beginning, as many of the partners were not familiar with the concept. So the integration concept was also challenging, how to integrate in WHOI. So but after the constant follow-up and meeting, actually it became easier. Another challenge is that the financing. Our idea was that after 1 year of engagement with the partners, they will be able to actually run the program by themselves. They will be able to fundraise by themselves. But the problem still remains, because the partners are also dependent on external funding, and external funding for mental health is already limited. So it's actually quite challenging to scale up, even though they have the capacity and willingness to do it. Another challenge was the language barrier and translation. So because we had only in Arabic and English language translation of the audios, but there are also people from other languages, and so we needed to translate the sessions, and then it actually made the sessions longer, so people have to stay longer. So actually that was not quite good. So in future interventions, we suggest that actually we need to actually develop more adaptation and more translation into local languages. And as I said in the beginning, partnership is a long process, and actually we need to actually allocate more time in the partnership development process, starting with the teaming agreement up to the actual signing of the partnership. Currently, Self-Help Plus is being implemented in Ukraine, also by WHO and Health Rights, and in Kenya by Health Rights, and in South Sudan in partnership with Amref Health Africa. We are actually also implementing the similar model in South Sudan with them. And if we did not have a conflict in Palestine, we would have already started our Self-Help Plus 360 model in Palestine with our Danish partner, but this is now on hold. And there are many other partners that are interested in scaling up this approach in Tanzania, in Kenya, and in Ethiopia. In conclusion, we actually see that the importance of stakeholders' involvement from the very beginning. We actually involved all the staff, stakeholders, like staff from the beginning, but I think we only involved the potential partners at the implementation phase. And now we learned that actually it would have been much better if we had also involved the potential participants also from the beginning. And actually language adaptation of the Self-Help Plus audios are really important to actually, though translation was helpful, but the actual audio was always preferred. Though people spoke English, they still wanted the audios into local languages. Now our partners have the capacity to actually implement this Self-Help Plus intervention. So it's a success that we have together achieved, but the challenges is of the sustainability because of the funding. Finally, I would like to thank the stakeholders, the refugee community, the government of Uganda, especially the Office of the Prime Minister and the Ministry of Health, the World Health Organization, especially Ken Caswell and Teresa O. They really helped us throughout the process, and our donor Elra, especially Ruth and Jake and Shirin, they really provided a great support and not only on finance, but also guiding on other program aspects. So we are very thankful to them. We are also thankful to the colleagues from UNHCR Uganda. There are many colleagues, so taking names might be challenging. So I thank all of them in bulk, and also colleagues from Refugee Welfare Council and all the humanitarian agencies in Rhino Camp, Mpepe, and Kuriando refugee settlement in Uganda. Thank you very much.
Thank you so much, Nauraj, and Max as well for the very informative presentations. I'm opening the floor for discussion now, and if you have any questions, please write them in the Q&A, and then if you would like to read your questions out loud yourselves, please lift up your hand, and then I will unmute you. And maybe to start off the presentations, Nauraj, you talked a bit about challenges in including participants from the very beginning. You talked about including the staff at a very high level. And then we know that in participatory action research, stakeholders are actively engaged right from defining the research problems, that is very early on in project conceptualization. And my question here is, in SH Plus 360, there are elements of co-creation and co-development, but how can we structure programs and projects like this to allow for active engagement of target impact groups much earlier on in the conceptualization of the projects?
Thank you, Jackie. Actually, we learned that as we did the co-creation workshop with the staff at the various level, and I think we could have also done a series of interaction with the potential participants from different regions, like from the Kampala, the national level, and from Arua, and then from the refugee settlement actually in the community. So actually, we would have received the different perspective of the stakeholders at different levels, so that we would have actually even designed better intervention, so that the knowledge of the staff of the partner would be complemented by the knowledge of the other stakeholders at the different levels. So I think that is our learning, and I think any future Self-Help Plus 360 initiative, we recommend that actually in the co-creation process, we also do a kind of theory of change workshop with the target impact group, but at a different location, and so that we are representative of all the potential participants, so that we of course we can take the action research principle, but I think the theory of change workshop would be even much better, because then we will be actually targeting what change do we really want to get from integrating Self-Help Plus into this programming, and how it will affect you as a participant, how it should affect you as a staff, as a local community, as a government entity supervising or supporting the population. So we'll have a greater understanding, and then we can design a good intervention.
Thank you, Nauraj. Thank you. Right. Please write any questions you have in the chat. I will be keeping an eye on that. Yeah. And maybe I can ask Max another question while we're waiting for more questions to come in. Max, in your introduction, you talked about Self-Help Plus and how you use briefly trained specialists, and we know that there's been some discussions about quality assurance when we're using task shifting and task sharing. And from your experiences, how did you ensure that the intervention facilitators for SH Plus 360 delivered the intervention as intended? And you can speak to that as well, Nauraj, if you're able to.
Yeah, thanks, Jackie. That's really a very important question. First of all, before the lay provider starts delivering the intervention, there's an extensive training that is provided for them. It's a week-long training where the content is elaborated and explained to them during the training, the opportunities for them to role play on the actual content. And during the actual delivery of SS Plus, there's a close supervision by the intervention team leader. And the facilitator sits on a daily basis to debrief on activities that went well during the sessions, what aspects can be improved. So all this helps to keep the quality of the intervention on track, and it helps us to monitor and to determine that the facilitators were actually delivering the content that is expected.
Yeah, and the another aspect is that the content quality is maintained by the audio, so that actually the facilitator's main role is actually to manage the group, to actually show the pictures on time, and also to encourage the discussion as guided by the audio. So the audio actually monitors and actually audio manages all the technical content, so there is no risk of misinterpretation or inconsistencies throughout the in the different places of when you are running the session by facilitators themselves. So the audio is actually maintaining the quality of the technical content. So there is no room of misinterpretation, because audio is actually repeatedly. Audio also actually repeats the same concept over and over again in a different context, in a simplified language. So the quality of content is already maintained by the audio. Second, we also have a co-facilitator in this in this implementation, and co-facilitator also actually talks about the challenges of the participants in the session. Also manages any challenges like emotional challenges or any practical challenges. So we are taking care of other aspects that might also compromise the quality. So that's taken care by co-facilitator. And thirdly, as I mentioned before, we are very, very serious in actually developing the competencies of the supervisor and the facilitators. And so we are constantly measuring their competencies using the WHO's ensuring quality and psychosocial support equip the competency assessment tool, so that there is a rigorous process, and we see how facilitators and supervisors are improving in terms of their service delivery and supervision skills. That ensures the quality service delivery.
Thank you, Naranj. I'm just adding, so Naranj mentioned EQUIP, a competency assessment developed by the WHO. I just added a link there for everyone who'd like to look at it in more detail. Thank you, Naranj. And again, please include your questions in the Q&A. We're very happy to hear all even your thoughts and reflections on this session as well. Another thing, we might have funders in the audience today, and in your barriers to scaling up SH Plus, we see that a lot of them are linked to have financial connotations to them. What do funders need to know to accommodate this type of scaling, this type of multi-sectoral integration? And yeah, Max or Naranj.
Okay, Max, would you like to go first or?
Go ahead, Naranj.
Okay. Okay. So actually, look, so we are working in a conflict setting, in a more poverty stricken setting. So the expectation of the participants is very normal, very natural. So in terms of expectation, but then how do we actually explain them the aspect of the intervention? Why actually there is no material support? So why this intervention has to be like voluntarily. So you actually come to actually help yourself. So we don't want to actually in a way motivate you to come, because it has to be yourself to support yourself. So it's kind of self-help. But saying that, I also recognize that we need to include the livelihood component and other material support project together with this, so that there is a synergy, so that people can get both the support in one basket. So I think, for example, in BRAC, they already have the livelihood component, and we integrated psychosocial support. So it worked very well, so that they had both the aspect of the livelihood support, materials support from there, and psychosocial support from us, like from this intervention. So one is that, greater awareness about, why this intervention is designed and why we don't provide materials support in this intervention. And then, and the second aspect is that how we actually integrate this intervention to other, intervention that do provide materials support, and that do have impact on psychosocial and mental well-being of the participants.
Thank you, Naraj. And I hear that you're talking about synergizing, making sure we have multifaceted interventions that are holistic and then can address multiple concerns of people at the same time. Maybe just to round up the discussion today, what is next for HealthRight? What is next for SH Plus 360 in terms of multi-sectoral integration? I think we'd all love to see how we can further continue this great work that you've been doing in mental health and psychosocial support.
Shall I go? Or
Yes, please.
okay, Max, go ahead then.
Yeah, thanks, Nawarat. I think there are two important parts for HealthRight to take. One is HealthRight is happy to continue the technical tailored support model through SS Plus 360, help partner organizations to integrate SS Plus into their routine programming, for example, by training their facilitators and helping in the necessary adaptations that need to be made before integration starts, and quality supervision to ensure that SS Plus is delivered in the right format. But also, HealthRight is open to joint program proposals that are able to address, for example, SS Plus delivering alongside other programs in humanitarian programming. So two important parts, in my view, for HealthRight as next steps concerning SS Plus 360. Thank you.
Yeah, thanks, Matt. I want to add something else. Actually, we want to actually expand Self-Help Plus 360 not only in Uganda, but in other countries, and we want to develop the Center of Excellence for Self-Help Plus in the first in East African region, and then slowly then we actually expand that globally. So the idea is that our partnership with AMREF Health Africa South Sudan is one of them, and then actually we also have started some discussion with the colleagues from the WHO and the African region and the country offices of the WHO and other partners. If we can get some funding to actually start the Center of Excellence, where not only HealthRight but other organizations like BRAC, the Ministry of Health, the AMREF Health Africa can also actually send their staff to actually develop the capacity of other NGOs, other organizations. So actually, we want to expand this pool of the qualified trainers in Africa and in other parts of the world, so that actually we can expand through collaboration and partnership. Not only our own expansion as an NGO, but we want to actually expand as a group that looks at the quality and excellence in Self-Help Plus integration into the programming of the humanitarian partners.
Thank you. Thank you both. We've come to the end of the webinar today, and I think what we heard today was very informative. And just to maybe sum up on some of the points today, we talk about restructuring and adapting funding and support systems, like Naraj was just saying now, to accommodate for this added value of multi-sectoral interventions. And we also talked about simplicity. In mental health and psychosocial support, we always talk about complex interventions, but maybe simplicity is the way forward in scaling up interventions, as we have seen with Self-Help Plus, right? So thank you to our speakers. Thank you, Naraj. Thank you, Max, for today. And thank you to all the people who attended. We appreciate you coming in and taking your time to attend this webinar. And hopefully we can all collaborate in the future, working on mental health and psychosocial support. Any last remarks, Max and Naraj?
I just want to thank everybody for turning up for this webinar. SSPAS is a highly scalable intervention. We are asking partners across the globe to take it up and integrate into their programming. Thank you.
Yeah, I would also like to thank everybody for taking their time to attend this webinar, and so thank you very much. And one piece of news that I want to give is that this Self-Help Plus 360 has been actually evaluated independently by the independent evaluator, and actually they have found that it is really effective. And then after that, they have actually developed the case study of the success case study of our intervention in Uganda. So Self-Help Plus 360 model is now independently verified and shown to be effective. Secondly, we are also actually developing lots of communication material to support the scale up on Self-Help Plus. We are developing the case study booklets, the video documentaries and TikTok videos, and the other newspaper articles that will all support in the scale up of the intervention. If any other stakeholders are interested, we invite them to also look at those materials that will be coming out from us in the near future, in few months' time. Thank you very much. It's a pleasure speaking with you, and thank you for your time.
Thank you all.